Well, as we've heard already, we need policies and programs that make healthy food more available and to decrease the unhealthy food. And of course, help people to learn about food and nutrition. And we've been very fortunate to have this wonderful panel that we had of elected officials who are on the forefront of creating policies to bring about a healthier society. In order for decision makers, such as the people we heard today, to propose appropriate policy, they need evidence as to what works. And obtaining this evidence is not so easy. Over the past decades, we have seen many programs and initiatives that are focused on promoting healthier communities. They rely on a multitude of strategies from, as we heard today, so increasing supermarkets and green carts, to putting a 16-ounce cap on sweetened beverages, to the Department of Health's Stellar Markets that teaches people skills at the farmers markets and also provides them the opportunity to get $7 worth of fruits and vegetables using their health bucks for $5 worth of the SNAP benefits, to many, many more kind of programs out there. With so many programs and initiatives at play within the same communities, we need to develop reliable and valid methods to evaluate which strategies that are out there are working, or maybe which together would work in combination. That way we can determine which strategies we should scale up and which strategies that can be used to inform policymaking. It is a challenging and messy job for researchers and evaluators, but fortunately we have here today capable individuals who are extremely good at this. They will share with us what they have learned about conducting evaluations in naturalistic settings, so as to be able to identify what is working to effectively bring about the changes and the outcomes that we all seek. So now let me turn it back over to Madelyn Fernstorm to begin the panel discussion.
I think a note of thanks for the tireless efforts of researchers, nutrition educators like Isobel and all of her colleagues that have worked for decades bringing this to the forefront. So in large part, we are where we are with this kind of a foundation and contributions because of the efforts of academic people who reach out and do a lot of the groundbreaking work. So many thanks to Isobel and her team and colleagues. So now we're going to learn more about, well, how do you gather evidence? How do you know what works? And we have a fantastic panel who's going to tell us all about this. So first we have Jamie Bussel, who's the program officer at the Robert Wood Johnson Foundation, directing one of the foundation's largest community action initiatives, Healthy Kids, Healthy Communities. This fosters multidisciplinary partnerships and systems-level change strategies to transform the health of people and places. Next, we have Dr. Noreen Clark, who is the Myron Wegman Distinguished University Professor of Public Health and Director of the Center for Managing Chronic Disease and the former Dean of Public Health at the University of Michigan. She conducts studies on systems, policies, and programs that promote health, prevent illness, and enable individuals and communities to manage disease. Welcome. Dr. Nicole Harris Hollingsworth is the Senior Director of Community and Population Health at Montefiore Medical Center, where she oversees creation and implementation of community and population health strategies and interventions. She also, as I'm really happy to say, has obtained her PhD right here at Teachers College. That's always worth a round of applause. And Dr. Susan Casagra is the Assistant Commissioner, the Bureau of Chronic Disease Prevention and Tobacco Control for the New York City Department of Health and Mental Hygiene. She spearheads innovative programs and policies to increase healthy eating and physical activity among New York residents to prevent and combat obesity and chronic diseases. So important. So thank you very much to our wonderful panel. And what we're going to start is a brief overview of about 3 minutes or so in different areas. So first for Dr. Noreen Clark. You've been involved in the evaluation of the W.K. Kellogg Foundation-funded food and fitness project that's worked since 2007 in 9 communities around the country, with New York City being one of the communities. In this project, communities created action plans to move forward health-promoting and sustainable food environments. Can you tell us a bit about this work and specifically how you've evaluated the impact of the food and fitness projects, and what were some of the challenges and how were they overcome?
Well, it's a real pleasure for me to be here this morning. I'm a graduate of this illustrious institution. And I compliment everyone associated with this really remarkable event and establishment of this center. So the Kellogg initiative is a very interesting one in which there have been really 2 major threads. The first is to make accessible, primarily for children and young people in low-income areas, healthy, locally grown food, and to do that community-wide, but with particular attention to schools. The Kellogg Foundation, as many of you know, have a strong interest in children, and particularly school-age children. The second theme is equity and engagement. So there's an interest not just in seeing the impact on food and also areas for physical activity. There's an interest in seeing how the processes of equity and community engagement play out in these communities and enable them to forward their goals. So our center at the University of Michigan is the cross-site evaluation team for this effort that's in, as was mentioned, 9 communities across the U.S. And when I think about the ways in which we've tried to figure out what's going on, how do you know what works? There are several things that have been very, very important to us as evaluators. One is that we have established very close relationships with the local project sites and evaluators in those sites. Now, these relationships are of long standing. This project has gone on since 2007. They're close, they're frequent interaction, and collaboratively, we've designed the evaluation and the tools for evaluation. This collaboration idea is something I hope we can come back to. We're also collaboratively with the local sites implementing cross-site tools that we have developed to look at policy changes that have occurred in these communities, to look at collaboration, to look at resources, how they've been deployed. And one of the big challenges that I want to put on the table for conversation is that evaluation is a collaborative activity. It has to be done collectively. And one of the biggest challenges is ensuring every one of the stakeholders, from the members of a collaborative to the leaders, to the evaluators, to the policymakers, understand why evaluation is being done and what the focus will be. That evaluation is for learning. It's not pejorative. It's for identifying accomplishment. It's for fine-tuning. It's for removing obstacles, and it's for sharing information. But if everyone is not on the same page, there won't be enough data, there won't be enough information to really figure out what's happening and what works.
So that's a wonderful beginning to this, because getting everybody on the same page is so important. And I'd like to turn to Jamie for a minute from the Robert Wood Johnson Foundation about all the kinds of things that you fund. And how do you identify what a good project is? How do you evaluate this? I mean, this is going to be the topic of our whole discussion, but I want to get a little snapshot from each of our speakers about these particular questions, and then we'll have a more general discussion. But what do you look for, and what are you doing to address this problem?
At the foundation, I think we really go with the mantra that what gets measured gets changed. And so it's rare that we would be investing in sort of any programmatic endeavor without a really thoughtful evaluation. I spend most of my time on our childhood obesity prevention portfolio at RWJ, and I actually should have backed up for folks that are not familiar with the foundation just to say that RWJF is the largest foundation in the nation devoted exclusively to improving the health and healthcare for all Americans, particularly those most vulnerable. And we share sort of this lofty, big, hairy, audacious goal of decreasing the rise in childhood obesity prevalence by 2015. And I, like Speaker Quinn, share also the sentiment that I think we can and will get there. So having said that, again, as I said, I think what gets measured gets changed. And we have always had, over our 40-year history, I think a real deep commitment to the importance of evaluation. Under obesity, we have been that's okay.
But it was a proper coughing
We've
technique,
already gotten to know each other
public
very
health
well.
right here today.
I'm in recovery, and I'm not quite there yet. I apologize.
So I'll just mention, too, I think early on when we embarked upon our childhood obesity prevention efforts now back in 2002, there was a paucity of evidence, I think, around environmental and policy determinants of both healthy eating and active living, and we have certainly come a long way in part to many of the research initiatives that we're funding, too, in particular active living research, which is housed at San Diego State, run by Dr. Jim Salas, who is a world-renowned physical activity researcher. And on the parallel track, Mary Story, who is an amazing champion of all things healthy eating, and Mary's at the University of Minnesota and runs our Healthy Eating Research Initiative. And again, this is all about building the evidence base around environmental and policy determinants of healthy eating and active living, something that typically NIH does not fund. And so the foundation has always been in this space. And again, just want to emphasize, I think, the importance of measuring for change.
We're going to be talking a lot more about that in this panel. And now, thank you for that. It was very succinctly put. And now, Nicole, you've worked to create community-based programs effective at changing eating behaviors. And Montefiore has been a real leader in the Bronx. And maybe you can share what you've done to determine how do you evaluate the impact of your problem. Design and implementing is one thing, and then how do you measure your results?
Well, at Montefiore, which is not only one of the largest institutions in the Bronx, but is also the largest private employer, we're faced with the knowledge and awareness that 1 in every 4 Bronx residents is involved in healthcare. So there's a different sort of approach to healthcare that we take because we think that so many people have their own perspective on this. So when we're looking at our evaluation, we have sort of 3 platforms. We look at a standard-based evaluation, a lot of measurement and standard evaluation that are done in partnership with other academic institutions. But we look at community acceptance and knowledge change, and then we look at consumption variations. And for us, those are the key evaluation factors because we're not then able to evaluate if something has changed unless we see movement in any one of those 3 areas. We've had a number of programs, and Susan and I work very closely together. New York City Department of Health and Montefiore are very good friends. And so when I look at 3 of our programs, specifically one done in conjunction with the Tisch Foundation around green carts and the Locardo Initiative, and talking a little bit more about the initiative, green carts were everywhere. We had health centers that were everywhere. We wanted to be able to track not only where the green carts were, but also how people were using them and how people could find them. We received funding to actually work with the green cart vendors to have cell phone-based locators so that people could find them and then to track where those individuals were. Did they match up with where they said they were going to be? And then, of course, was there increased consumption of fruits and vegetables in those neighborhoods? We balanced that against the community health survey data that we got from City DOH, and so it actually fit all 3 of our platforms. We utilized the standard evaluation measure, we looked at changes in behavior, and then we looked at increases in consumption. And so for us, across all of our programs, whether or not it's basic cooking demonstrations and introducing people to fresh fruits and produce that they may have never consumed, you would be surprised at the number of people in New York City who have never eaten a piece of broccoli. And other programs, you'd be surprised to know how many people haven't been engaged and how utilizing those 3 platforms allows them to better engage and allows us to better evaluate what's happening with them.
Wonderful. That's great. And this is a natural segue into some comments and a question for Susan about the New York City Department of Health is amazing, has implemented a lot of different programs. And the first question I have for you is, what have you learned about evaluation and how the impact of your policies and community and in your impact on changing behaviors, changing the efforts, and what all of these outreaches have done?
First, I also wanted to thank Teachers College, Columbia University, and my esteemed panelists as well for the opportunity to be here today, and especially the Laurie Tisch Illumination Fund. We are so proud of the Green Carts Initiative and feel very lucky to have done that, so thank you again on that. As far as what we've learned about evaluation, I think, when you talk about a lot of the approaches that you've heard today, they are policy systems and environmental changes, and how you evaluate those types of interventions are very different than how you evaluate health interventions in the traditional sense, because a lot of health interventions in the traditional sense are on medical interventions, for example, or the types of things that are funded by NIH that you mentioned, Jamie, are, for example, clinical trials that focus on individual level interventions. Like, for example, if you get blood pressure medicine A versus B, and looking at the differences there. When you're looking at interventions that you apply across broad populations or large segments of the population, the methods that you use there are very different. You also want to measure that impact on the population. And I always use an example from the tobacco control world, which I also work in, and that's our smoke-free air policy, for example. Here in New York City in 2003, we were fortunate to make all our bars and restaurants smoke-free. You can't, for example, give somebody smoky air and non-smoky air and measure the impact that way. When you look at the impact on any one individual, it's very hard to see that. But when you look across the entire population and use methods, for example, like surveillance, you can see, for example, the rates of lung cancer coming down or exposure to secondhand smoke coming down. So there's a different type of methodology that comes with public health interventions that involve policy systems and environmental changes.
And so how would you, this is such a key point, because how do you translate population data that you need to do for scalable initiatives to the individual? When people hear statistics and even, policy groups, how do you translate that and explain what even a tiny change maybe in a large population data piece may show versus how does that affect the individual?
So I think what you said, that last line was very important. Tiny changes across the individual can make a broad change across the population. So I think being able to kind of translate the number back and forth from the individual to the population is very important. And I think that's a tricky thing to do, again, because the methods that you use to make both of those numbers are very different. But they are possible to do, and that's using non-traditional methods of evaluation, such as, for example, surveillance, or, for example, projecting impact using modeling. It's, again, before you put the Smoke-Free Air Act, it's hard to determine what the impact. The only way to do that is perhaps if you model or project out the impact, before the policy took place. So I think there's very different methods, but it's very possible to do.
I was very glad that you raised the tobacco issue, because I think if you think about how change has occurred in a massive scale related to people's health in this country, tobacco is a very good example. And it picks up on Susan's point in the following way. It took a long time to see the population-wide behavior change of smoking cessation. And over that period of time, which was at least, what, John, 20 years, 25 years, there were very many strategies that were utilized. You couldn't do a controlled trial. And these strategies were, over time, documented in the more innovative ways that Susan is talking about. And there was an accumulation of evidence that we were moving in the right direction. I think this is really the issue for the food and obesity problem in this country. In fact, we need to bring about policy change, as our panelists were talking about earlier this morning. So that means we need to track policy. And it's possible to do that. We're doing that in the Kellogg initiative. We're tracking policy. Then you begin to look in the same populations where these policies have been modified to the kinds of things that Nicole was describing. Are there changes in some of the population statistics you look at? One of the things that I think evaluators get a little crazed about, and maybe it's the way that we educate them in graduate schools, I'm not excluding my own, I might add. We get really crazy about statistical methods and statistical changes. My whole career I've worked in low-income communities. You want to be unwelcome early on? Talk about those kinds of things, right? What we need are very community-friendly tools that help us track, are we moving in the right direction? Is there a plausible connection between what we're seeing in a policy change and a behavior change? And I think we really need to shift our perspective when we think about evaluating in these complicated community situations.
Right, but a very important element of that evaluation, and Borough President Springer brought it up earlier, is nurturing that from the ground up. Because so often, you know, when you go into a community as a researcher, you know, they're like, I don't want to hear about it. I want you to solve my problem immediately. Right. And so much education has to be done to even allow a collaborative process for evaluation to begin, because otherwise you're not going to be able to get any data out of it. You will go in for 2 years, have a wonderful project, leave, and the community will resent you for that.
Yes. And we say evaluation, but that's really a broad term. And I think when we are speaking of it now, part of it is that we're talking about health impact. We're all here because we're focused on health. But, you know, to the people that were sitting in these chairs before, there's a lot of different types of evaluation that I think matter to them. For example, doing a public opinion survey and figuring out how many people support the intervention that has that health benefit. That could be important to the people in this room. Or does it create jobs? You know, we mentioned green cards. Does creating new jobs? That could also be important. So you could evaluate in many different ways, and many different end outcomes could be important to the community.
Right. And outcomes of a partial response. It's never going to be, even with treating chronic disease, it's not 100% of people responding. If you have a 20% or 25% in these kinds of large endeavors, it's hugely successful. And in that note, I want to have one question, because you all come from very different vantage points. And the question is this: sometimes we learn a lot from what hasn't worked. And as we move ahead, we don't want to reinvent the wheel. And, you know, everything old is new again in so many of these areas. I mean, starting with you, Jamie, is there something you've thought about or invested in that it turned out, gee, this wasn't a good idea, and why was that? And did you learn, what did you learn from that changes how you focus on evidence-based information?
You know, I'll say, I think so often the tobacco parallel is made, and again, there's a lot of differences. Tobacco, it's a binary decision. You know, we all need to eat. It's not a binary decision. So this is arguably the most complex public health challenge that we have ever taken on as a nation. I think, you know, way back in 2002 when we launched our childhood obesity prevention effort, there was a possibility that we may go into a more individually oriented behavior change strategies or the policy and environmental change. And I think we learned a lot from our at least decades-long investment in tobacco, and where we made our greatest inroads in decreasing tobacco prevalence were when we focused on three things. And I'm not saying that we'll get to sort of three things in obesity, because I think, you know, as Laurie articulated earlier on, this is going to take a multi-pronged approach. But having said that, with tobacco, it was clearly clean indoor air, tobacco excise tax, and counter tobacco advertising. And that's how we made our greatest inroads in decreasing tobacco prevalence. And I think we really used that to build sort of a huge portfolio and engine around environmental and policy, both investing in that at the community level, investing in evaluation, and clearly investing in an evidence base that really needed to be built way back then. So
excellent. Noreen.
I would say that the biggest mistake that I personally have made, and I've seen others made, the council president made himself, and that is to think that there is a plan and one way to get to the goal. And as Jamie has pointed out, this is an extraordinarily complicated, complex problem. And I think one of our challenges is to figure out which dimensions of solving this problem are held in common, particularly across low-income groups, and which dimensions are very unique. And in both those situations, it's enormously important to find out what it is that's going to lead people to either the policy that needs to be changed, the behavior that needs to be changed, the infrastructure, or the service that needs to be introduced. And so it's an ongoing process of dialogue about what the policy change ought to be, for example, and how will we know if that policy worked, and what kind of data sources do we need to have? So the other big mistake I've made and I've seen others make is to think that there are one or two data sources that will explain the change or lack thereof. And that is why I believe that in any of these evaluations, we need to have data that are coming from people who are affected, policymakers who are introducing policies, documents that explain processes. There's no one piece of data or statistic you can look at that's going to give you the level and nuance of answer you need to have to know which path to encourage and follow.
Thank you for that. And before I turn to Nicole to give her response to this in a really challenging area, I'm going to encourage all of you, if you have some questions or things you'd like our panel to discuss, fill out one of the cards that will be available to you and pass them to the end of the aisle where a meeting representative will bring them up here. So we would encourage you to no question is too small or too trivial, because we would love to hear what you have to say. But now we would like to hear from Nicole what she has to say in terms of mistakes that you've made or policies you thought that would have worked and didn't, and why.
Well, actually, I think the largest mistake that we made was thinking that the data that showed that this was a problem in the community was actually perceived by the community to be a problem. Very often, we look at data and statistics and we're like, oh my gosh, everyone has, everyone is overweight, everyone's not eating properly, there's not enough fruit and vegetable consumption. And not that those aren't important issues, but they coexist with other very significant issues in the community. And so if someone is choosing between eating healthy and paying for housing, and eating healthy and medication, right. Not to just say, well, don't pay attention to that, you need to eat healthy, but to find some way to balance that out. And we find that in doing evaluation of our variety of programs, when we're able to balance that out more effectively, we're able to have better receptivity to healthy eating messages, to other types of interventions, and we're able to get cleaner and better data because we are not ignoring the larger and sometimes perceived pressing needs that exist in the community.
What do you think? I mean, there's been a lot of home runs with the Department of Health, from large sodas to trans fats, everything else. What have you learned that things that may have not turned out the way you thought, and was it a surprise to you?
We have had a lot of successes, and we're very thankful for the strong leadership that has made that happen here at the City Health Department and for the city. And I think in terms of what we have learned, I am a firm believer in evidence, evidence-informed decisions, evidence-based decisions, and I think it was our mayor who said this, but he said, in God we trust, all others must show me the data. And so that's how we do operate. But I think one of the most important things that we've learned is that also, along with the data, you have to put that into context, because it will not be perceived, or it could be perceived very differently by different people. And I'll give you an example. And again, this example is from the work that we do also in tobacco control, because that is, I think, a really great example, going back to the Smoke-Free Air Act. The world's expert on secondhand smoke spoke about the Smoke-Free Air Act, the benefits to our city council, and they heard all sorts of data, and I have a tendency also to spew out data, 58% of New Yorkers obese, 44% of kids, but what really spoke to them was that pregnant woman who works in a restaurant every day and is exposed to secondhand smoke. And so it's really important, not only are you making those data-based arguments, but you're also making those value-based arguments and really putting it into context for people to understand what this means in the community.
Yeah, I think that's a critically important point, because I think so often, we're numbers people. The foundation cares about numbers. I find myself on all the calls that I field every day. Okay, so what's the data? What are your outcomes? And at the end of the day, that anecdotal evidence can be particularly compelling. And so I would hate to sort of, get away from that, because I think there is nothing more compelling than a story. So.
Well, and I think the issue is to find the balance. I couldn't agree more. And I'll give you an example out of the cross-site evaluation that we're doing for the Kellogg initiative. We have tracking of policy changes, both larger scale policy, as our elected officials were talking about this morning, but also organizational policy change, which can be extraordinarily powerful, although occurring at a different level. And an example is, although it is not true in New York City, in many school districts, in many school systems, districts and schools themselves have a lot of authority over the policies in those schools. Procurement, for example. So we've followed policies through a tracking form that's used in all of these sites, and we're identifying many, we can put a number to them. We can put a number to how many people are implicated in the policy change. But at the same time, we're asking people in the communities where these changes are being introduced to tell their story about the policy, so that they describe their either experience in being involved in trying to bring about the policy change or the impact on that change in a more personal kind of way. So I think having both sorts of data are extremely important because of the very point that you raised, Susan, that people make policy decisions for a whole lot of reasons. Evidence is one, but not the only one.
And I just want to clarify one point, and this was mentioned earlier around food procurement, New York City not having regional-based food procurement within the school system. But in New York City, we have a food procurement system for the entire city government. So, for example, whether the meal that you eat in a homeless shelter versus a school versus even in a jail, any place that is food is served by city government meets our very stringent nutritional criteria, and it impacts over 260 million meals served across New York City. It also impacts 3,000 some vending machines that we have on city property. So it's a very broad standard, and that's an example of an environmental change that is really changing the defaults in our community.
Do you think it's possible, perfect world, that in data collection, of which I am part of that world, that when you look at things, we talked about the personalization of the message, that telling someone, or a woman, for example, head of wholesale, you want to eat healthy because it's good for you, is the message, and can you actually compare the information you would gather otherwise of saying, if you're not eating well, if your weight isn't stable, if you have diabetes, you're not going to be able to care for your aging mother, take care of your kids, go to work and manage all of this. That it's the carrot and the stick approach that you need to really evaluate to see how is the message translated. Is it better to say, here's why it's good for you, or to compare it with something that goes, here's why you really want to do it, here's what's in it for you, because for so many people, sadly, good health is not its own reward. And it is in that way very different from smoking. Do you have any thoughts about being able to collect more personalized messages?
I think that it's better when the message, when both messages are provided simultaneously, because very often you're going to get a response one way or the other. One of the situations that we have happen very frequently is New York City puts out some very prolific advertising as it relates to pouring on the pounds and a number of other issues. And we have individuals who respond to that very negatively, but who will respond very well to, hi, I changed my life, this is my story. When you put those two messages together, they're more receptive to both messages because they coexist in the same space. And so I think it's tremendously important to not single out the messages. I think one of anything is bad is because our communities are just so very diverse. And, in profiling our communities, who we expect to be there very often isn't the person that's there, and who's receiving that message. When you think of the Bronx, all of us have a different image of the Bronx depending on when we interfaced with it. You talk to our borough president today and he'll rave about it. You'll talk to someone whose experience was 40 years ago and it's a very different experience. But you need all of the kinds of messaging there. Without that, I think that it is a deficiency provided to that particular population, and you're going to lose and stereotype and end up with a lot of what you have already.
And I think the messaging research is critical, as I do think the messenger is critical as well. So the foundation's absolutely been investing and will continue to invest in the message research, the public polling. I mean, all of those things. So
yeah. We've been.
Sorry. I think an important dimension of the question you've raised is messages to policymakers. And I think that's a very tricky bit of business. On the other hand, we found, now this has been working primarily in local areas, we found that these collaboratives can find ways to frame their desired policy change that is very resonant with something that their local policymakers are interested in. So it's to a certain extent, and since the Kellogg initiative is really the focus is system and policy change, policymakers are important targets. And I think to a certain extent it may be a little more easy to find messages that fit policymakers who have similar goals to a certain extent, serving their community, than it is individuals. I think individuals, it's very tough.
We've been fortunate to be able to do some of these campaigns that Nicole had mentioned, such as pouring on the pounds. And talk about evaluation. The evaluation process that goes into figuring out what your message is, it's a very long and complicated process that starts with, for example, focus group testing among many different types of people, and something that we do. And one of the things one of the lessons that we've learned in doing these messages is that the messages that work are not always the ones that people walk away feeling warm fuzzies. It's really the messages that grab your attention and make you look at the TV, because let's face it, we have tons of things bombarding us every day. So it's really those types of things that make you, at the end of the day, talk to somebody and say, hey, did you see that ad? And a lot of those things tend to be things that are graphic, compelling, that are different than what's already out there. And that's why some of our strategies around pouring on the pounds and teaching new tactics, our cessation campaigns that show the graphic consequences of smoking and sugary drinks, for example. So that's been one of the lessons that we've learned.
Right. New York is a very activist city, and that very often our policymakers are informed by their constituencies. Yes. So to the extent that we're able to utilize messaging that influences sort of the every person on the street, it's when they bring those messages very often to their legislators that suddenly legislators become interested in, oh, well, everyone is very worked up about this particular issue. Let me know and learn more about that. And so I think having balanced messaging and messaging that's done in partnership. Each of our organizations is very large, and it is because we support a lot of DOH messaging that more DOH messaging is able to get out. Within community health and public health, even within a large organization, the resources are still extraordinarily limited. I mean, it's not like the public health people get all of the money to do this work. And so the importance of collaboration is key. It's absolutely key.
And that's actually leading to this. We have a few questions in our remaining minutes, and sort of this collaboration leads to part of what one question is what recommendations do you have for a small budget program to conduct some effective evaluation? This is really tough. Limited resources, maybe limited ability, statistical issues. How would you suggest a small program can connect to be able to collect some useful data?
Sure. I think with any program, there's a lot of little steps and little evaluations that add to the big picture. So I think there's a lot of little pieces that a smaller program could take. And I mentioned one of these examples, but for example, figuring out whether people support the intervention. A lot of times what you hear in the media is not what the popular public thinks, because oftentimes the media space is taken up by the very vocal opposition that might be the very minority, for example. So really getting at the facts on that, or doing key informant surveys about how you scale up an intervention, how you enforce an intervention. So there's very discrete components of implementing an intervention that I think smaller groups could take on.
I think, too, one of the almost simplistic but extremely important aspects of this is for the organization to have an internal dialogue about what do we want to know and how would we know that. And that conversation in and of itself can make everybody aware of the level of resources that exist in communities, even very poor communities. People know things, they know where information is located. So I think that internal dialogue, what do we want to know, and how could we find out the answer, is a very, very important undertaking.
So, another question that's sort of tied to this is on the other end of the spectrum. Given that it can take a really long time to see large-scale changes, how should policies be developed right now with limited data? And do you think limited data is not a good way to think about this? So you can have some evidence and enough to move on, because if you keep collecting data, more data are needed, that becomes a problem because you never get anything implemented.
You know, I'm sort of channeling Jim Marks, who's one of our senior VPs, and Jim would say, I mean, we all know, and again, in the spirit of full disclosure, I think I'm the only non-scientist or non-evaluator and researcher on the panel today, but science is slow, and we certainly can't wait for the science to catch up before we begin to do action on the ground. And so I think, you know, Jim says we need to be acting on the best available science, and I think there is something really poignant and important about that point.
Mm-hmm. It's the sequencing, too, I think, that often there isn't enough thought given to the authorities for pushing forward a policy or a service or an idea of the link between what will this activity lead to? Will it actually lead to people's behavior changing? Will it actually lead to a new policy? If that policy were formulated and implemented, would it actually lead to changes in people's health status? I think the sequence discussion is often missing in the dialogue about what works and what should we support.
And I just wanted to add too, because I think California Endowment is doing a great job around how they're taking on the evaluation of the California Fresh Works, which is the California's financing mechanism to bring markets back into communities in the state of California. And they go through exactly to your point, Noreen. It's sort of, you know, implementation, changes in access, community perceptions. These are all things that could be gathered well. And then the more distal outcomes around behavior change, we recognize are going to come a lot longer. Right. So it's patience too, I think.
Patience too.
And on our final question, just to wrap up this really wonderful panel, I'm going to start with Susan and Nicole. I'd like your weighing in on this, because this is a giant issue. How feasible is it to standardize some of the measures for either nutrition education or cooking programs to see what's most effective? We know one size does not fit all, but is there a way, do you think it's possible, to try and standardize some of this so our local blueprint could be used all over the country?
We have measures that we use in New York City to evaluate the impact of some of our programs. For example, looking at fruit and vegetable consumption, and we're very fortunate that some of these initiatives like the Green Card Initiative and others have increased fruit and vegetable consumption in New York City, and that certainly is a measure that could be translated elsewhere. You know, but to add a little bit to the previous point, perfection can't be the enemy of the good. So I think we do have to act on the best available evidence with the best available metrics and make an action based on those, because lack of action, that's also an action that has its own consequences. Right. That is not often measured, and I think that is not always compared. So I think we have to act on the best available evidence. There are some metrics that can be used, and it's time to move forward.
I think building off of Susan's point, what becomes important for us is really consistency over standardization. I don't think we're going to be able to come up with a standardized method for it. There are just too many variations. We live in too diverse a nation, let alone a city, for that to happen. But if we're able to collect the data consistently, there are several metrics, and some of the federal metrics that, when you look at the behavioral risk factors survey, when you look at the community health survey, when you look at NHANES, when you look at data that is collected across the board, it's really looking for consistency in practice, not necessarily standardization. And so I think that if there's going to be any way, that's where we should start.
I like that word, consistency in practice. And if there are no other burning questions, this has been I'd like to thank this panel who has really shared the challenges of doing this and achieved amazing things, because collecting of information that is useful and practical and can be translated to policy is more important than say, here's what the science says. Jamie had pointed out before. So thank you to this excellent panel. You've offered a lot of information. Appreciate it.